Hello, this is Amr El-Husseini. I'm professor at University of Kentucky. I'm professor of nephrology, bone and mineral metabolism. Today, I'm going to talk to you about very interesting hot topic, which is SGLT2 inhibitors that showed nephroprotective effects in diabetic patients and now also in CKD non-diabetic patients. As you know, that since 2016, we have several randomized clinical trials that was published in big journal, high-ranked, journal like New England Journal of Medicine. And there is at least six of them that involved thousands of patients that showed very good response to the SGLT2 inhibitor. In the beginning, there was signal toward increased some complications, especially UTIs, fractures, amputation. But I will walk you through this study and see where we are standing now from the use of SGLT2 inhibitors in our patients. I think I have to say that I don't have any disclosure. I'm part of several phase 3 randomized clinical trials, but none of them are related to diabetes. I'm focusing on bone research, but I don't get any funds from any of the pharmaceutical company regarding the diabetes or SGLT2 inhibitor. As you know, in the last couple of decades, there is increased incidence and prevalence of type 2 diabetes, and also there is increased incidence and prevalence of end-stage kidney disease. And diabetes as a leading cause of end-stage kidney disease has grown over at least the last 4 decades compared to other etiologies as GN or cystic kidney disease, which stayed around the same. So the question is how to prevent kidney disease and kidney failure in type 2 diabetic patients. There was several agents were tried in big randomized clinical trial. So as we know that ACE and ARBs are the most useful agents in this regard. And here you can see the Renal study and the IDNT study. They were successful in decreasing the kidney failure, doubling of serum creatinine, and improving survival by 16% in the Renal study and 20% in the IDNT using either the losartan or irbesartan. But this was old study, but in the recent, decade or decade and a half, there was several other therapies were tried, but all of them, as you can see here, failed to protect our patient from kidney failure or to slow the progression, at least, of their CKD. Actually, I published a couple of articles because I was very pessimistic about that, and I named it nephrology sclerosis as a field, and are we in a stagnant era? So hopefully, and I published this 3 years ago. So now I think we have a hope by the end of the tunnel with use of the SGLT2 inhibitors. So what does SGLT2 inhibitor do? So as we know, there is, the sodium glucose transporter type 1 and type 2. Type 1 is mainly in the gut. 10% of these are in the, what we call it, segment 3 of the renal nephron. But 90% of the SGLT are SGLT2. So it is in the proximal part of the renal convoluted tubule, and it's responsible for absorption or reabsorption of glucose. And as you know, that the renal threshold for the glucosuria is 180 milligram per deciliter in normal circumstances. However, in type 2 diabetes, you would anticipate that this threshold will go down so we can dump up more glucose in the urine, but actually this is not true. What happened is this renal threshold actually goes up, so patient hyper absorb glucose, and it's a reason that renal also, this is diabetes is not only endocrine disorder, but renal is a good part of this because the hyper absorb the glucose. So the idea was with using SGLT2 inhibitor is try to normalize this glucose reabsorption and try to dump up more glucose in the urine by inhibiting the sodium glucose co-transporter type 1. So they are all named Phlorizins, and it actually comes out from an apple tree that was discovered in 1935. And currently, at least at United States, we have 4 FDA approved SGLT2 inhibitor. The first one was canagliflozin, then dapagliflozin, then EMBA, and now we have also the ertugriflozin. So we have at least 4 of them. So is the renal protection or the mechanism of action of these agents are limited to the glucosuria? I think we are learning more and more now about this agent, and it seems that they don't only decrease the caloric load and the glucose reabsorption, but also it inhibits the RAS system. It's very important because it's also causes osmotic diuresis, so it's indirect diuretic. It decreases the albuminuria. It has antioxidant mechanism, and it decreases the arterial stiffness and the blood pressure. And moreover, also it can have anti-inflammatory properties. So it's not only proposed that it's good for the kidney, but also it's good for the heart, for the brain. It decreases the hyperinsulinemia, the hyperlipidemia. It improves the renal circulation. It increases the sodium excretion in the urine, improve vascular compliance and reactivity, and decrease the vascular wall stiffness and the stress on the heart. So the benefit is not only related directly to the glucose excretion in the urine, but beyond. Okay, let us focus now on the major clinical studies. We have 6 major clinical studies that has been published. As you see here, started from the EMBA-REG, then CANVAS and DECLARE. And all of these studies were focusing on the cardiovascular outcome, not really on the renal outcome. Then last year, CREDENCE, one of the very, very nice big study that was focusing on patients with nephropathy, mainly patients with proteinuria. Then this year, just August, 2 months ago, the DABA heart failure study was published. And as you see, all of them has been published in the New England Journal of Medicine. Then last month, just 10 days ago, the DABA CKD study was published. So the CREDENCE and the DABA CKD were mainly focusing on the renal outcome and the renal patient, and the DABA heart failure and the prior study focused on cardiovascular outcomes. Here is just a cartoon that describe how these studies were selected, their patient population. As you see, the initial studies, it depends on the albuminuria and the kidney function. The initial studies, the CREDENCE, the EMBA, REG, and the DECLARE, they enrolled the patient with at least GFR of 60, and the majority of patient has normal or near normal kidney function, or sometimes they are hyperfiltering and the eGFR is actually higher. But the CREDENCE study was the first study that included patient only with nephropathy, so included patient with proteinuria at least 300 milligram, and also the GFR, they went down to 30. So they included patients from eGFR of 30 to 90. Then the DABA CKD trial that was published 10 days ago showed that also you can use this in GFR down to 25. So the only recruited patient with eGFR between 25 and 75, and with proteinuria at least 200 milligram per deciliter. And here is a composite endpoint at different stages of kidney function in the prior study, the EMBA-REG, the DECLARE, and the CANVAS. And as you can see here, you see risk reduction in different stages of kidney function. But the initial studies showed some concern about limb amputation and toe amputation. There was almost two double hazard ratio of using the canagliflozin in diabetic patient in the CANVAS study. So this was a red flag in this study. So let us focus now on the renal studies, the CREDENCE, then the CKD, the DABA CKD study. The CREDENCE study involved more than 4,400 patients with type 2 diabetes, and the urinary albumin creatinine ratio all are more than 300 milligram, mean GFR about 57 ml per minute, and mean albuminuria is about 1 gram. And the primary endpoint was mainly focusing on the kidney, end-stage kidney disease, doubling serum creatinine, or renal or cardiovascular death. And here, the mean A1C for this CREDENCE trial patient were 8.3, so their glucose wasn't properly controlled. Blood pressure wasn't too bad. The mean is 140/78. And 99.9% of these patients were on ACE or ARBs. So this is an extra, it's an added benefit of using these agents on top of the benefit they get from ACE or ARBs. So the SGLT2 inhibitor is not proposed to replace the ACE or ARBs, but just to be used on top of them. And as you can see here, the CREDENCE study were able to decrease the primary endpoint by 30%. So the end-stage kidney disease, doubling creatinine, or renal or cardiovascular death decreased by 30%. And here is, as you see, the major benefit was from renal death. It's more than 60% reduction in renal death. So here, the main other concern of the CREDENCE study and other study was the initial decline of eGFR. So about 3.7 points lower eGFR in the CANA group in this CREDENCE study compared just to 0.5 in the first couple weeks. However, with long-term use of the canagliflozin, it actually have 60% reduction in the rate of decline of eGFR. And I think this initial decline of GFR is very anticipated because you decrease the interglomerular tension, the interglomerular pressure, so the glomerular filtration goes down. And also it showed that the albuminuria, decreased about 32% in the canagliflozin group. And interestingly, this study, the CREDENCE study, didn't show any increased risk or at least significant increased risk of amputation or fracture. Safety profile was very good. So this was published last year, early last year, and right after that, the ADA, the American Diabetes Association, it changed or updated their guidelines in June 2019, and they said for type 2 diabetic patient with chronic, with any kind of kidney disease, consider use of SGLT2 inhibitor if the GFR is more than 30%, especially with those with proteinuria of at least 300 milligram per gram, to reduce or slow the progression of the kidney disease and to improve the patient survival. And here, just last month, the DABA CKD study was published. So this also included very good number of patients. So in the CREDENCE studies, they include 4,400, and the DABA studies, they included 4,300 patients. eGFR here was 25 to 75, and the proteinuria was from 200 to 500 milligram. And it's very interesting that they didn't only include diabetic patients, but they include CKD non-diabetic patients. About 1/3 of patients were non-diabetic. As you see here, a very big study, 21 countries, 386 sites, and more than 4,300 participants from everywhere, except, sadly, or at least surprisingly, they didn't include or recruit any patients from Africa or from the Arab countries. The majority were from North America, South America, and actually Asian population were included in the study. About 1/3 of patients were Asian, and of course, European as well. And here is a study design. So they included, only adults, so age at least 18, and eGFR between 25 to 75, and urine album creatinine ratio at least 200 up to 5,000, and stable patient on maximal tolerated dose of ACE inhibitor or ARBs for at least 4 weeks. They ruled out type 1 diabetic, polycystic kidney disease, lupus nephritis, or ANCA-associated vasculitis, or any patient was on immunosuppressive medication within the last 6 months. They give 2 weeks of screening period, then they random the patient either to 10 milligram of dapagliflozin or placebo, and it was intention to treat the study. And here is the patient characteristics. Mean age was about 61 years old, and a majority were men, majority were white. So you can see here the black people, just very small percentage, about 1/3 Asian. They are, majority of them are obese, BMI of 29, smoking history just in 13%, blood pressure was well controlled in both groups. And here, interestingly, you can see the GFR. So the mean GFR was about 43 in both groups. And if you see the GFR of less than 30, about 14% of the whole study population had eGFR less than 30%. So we have at least a stage 4 CKD. And here is a proteinuria or albuminuria, about 1 gram. About actually around 50% of the patient had more than 1 gram of protein. And as you see here, about 98% of these patients were either on ACE or ARBs. Here is the results. As you can see, the primary composite endpoint went down 39%. This means that the 50% reduction of GFR or end-stage kidney disease or death, either because of renal or cardiovascular causes, went down 39% in the DABA group. Here is the renal specific endpoints. As you can see also that these outcome, which is end-stage kidney disease or 50% reduction of GFR or renal death, decreased 44%, very significant. And here is a cardiovascular outcome. As you can see here, the congestive heart failure admission and death because of cardiovascular causes went down 29%. And death from any cause went down about 31%. So very amazing, very good results. And I was interested also to look to the subgroup analysis. especially diabetic versus non-diabetic. As you can see here, at least the non-diabetic patients, they have the same beneficial response, if not better, compared to diabetic patients. The other thing was the AKI, or the decrease of the serum creatinine. Initially, it's very consistent among the different study that in the first 2 weeks, there is decline 3 to 4% or points of the eGFR. Then after maybe the first year or so, you start to see the difference between the eGFR in favor of the SGLT2 inhibitors. Here is a summary of the outcome of the DABA-CKD study. And as you see, the major impact was decrease of at least 50% reduction of GFR. And of course, all of the other outcome were in favor of using the dapagliflozin. What about safety? Well, it's actually looks like very safe, depending on the study and CREDENCE study. So discontinuation of the study medicine were it's the same in both groups. Discontinuation because of adverse events or any serious adverse events were very similar. Amputation, there was no signal for increased amputation. Fracture 4% compared to 3% in the placebo group. I think fracture, we need to study what's going on in the bone of this patient with actually long-term use of SGLT2 inhibitor. Volume depletion a little bit higher, and this is very anticipated. So we might need to tell the patient, especially if the patient doesn't have volume issue or congestive heart failure, to drink a little bit more amount of fluid, or to titrate down the diuretics, because these medications has indirect diuretic effect. So the conclusion in type 2 diabetic patient, SGLT2 inhibitor reduce the kidney disease progression, end-stage kidney disease, and cardiovascular disease. And actually in the DABA CKD study, 1/3 of these population were not diabetic. So also it did the same thing for CKD patient without diabetes. Risk and benefit must be closely evaluated in order to appropriately use SGLT2 inhibitor in CKD patient and in type 2 diabetic patient. I think now we need to focus on when and how and what is the patient population we need to use, and also focus on the long-term adverse events and the safety profile of these agents. But as you know, knowledge is of no value unless we put it in action, we put it in practice. So I think we need to get ourselves familiarized with this new agent, and hopefully we can help our patients with this agent. And thank you so much.